Good afternoon, and thank you for joining us today for our Thursday Stroke Week webinar. We'll be getting started very shortly. We're just going to give people a chance to log on and get settled. So while everyone is logging on, please make use of the chat function to let us know what site and state you are from. We'd love to welcome you more personally. So I can see there's a few people joining now, so we'll get started. Good afternoon again and welcome. My name is Ashley Mamo. I'm the Stroke Webinar Coordinator here at the Stroke Foundation. I'd like to introduce our presenter today, Dr. Jerome Ip. Dr. Ip is a consultant physician who is trained in the specialty fields of both geriatric medicine and neurology. He is currently a visiting neurologist at Hornsby Ku-ring-gai and Ryde Hospitals and staff specialist in neurology at Nepean Hospital, New South Wales. He has an interest in common neurological diseases of older people such as stroke, dementia, and Parkinson's disease. So on behalf of Stroke Foundation, I'd like to thank Dr. Ip for sharing his knowledge and expertise with us. We really look forward to learning from you today. We also have with us today Melita Sterling, who is Stroke Foundation's Quality Improvement Manager, and she'll be facilitating our discussion time today. So before we begin, I'll briefly run through some housekeeping. An interactive webinar is a good webinar. We encourage you to use the Q&A function at the bottom of your screen to submit your questions as you think of them, and we will answer your questions in the second half of this session. If you see a question that someone else has asked that you would also like answered, you can click the thumbs up button under the question to vote for it. All registrants will receive an email with the resources mentioned in today's session and a link to the recording. This email will also include a short survey where you can register to receive a CPD certificate. Now, please note that this survey will close on Thursday, the 18th of August at 5 p.m. Australian Eastern Standard Time. So it would be great if you could fill that survey out as soon as you receive it so you don't forget. Before we begin, we would like to acknowledge the traditional custodians of the lands on which we all meet today and pay respects to elders past, present, and emerging. I would like to acknowledge that I'm joining you today from the lands of the Darkinjung and Ku-ring-gai people. I'll now hand over to Dr. Ip to begin the presentation.
Thanks very much. Thank you. Thank you, Ashley, for the kind presentation and Stroke Foundation for the invitation to present today. I just try to make sure everyone can see the slide.
Yep, that's all good.
Good, okay. Yeah, I do not have any disclosure for this particular presentation. It is really a quite a big task and daunting task, to try to summarize the history of stroke, for a period over 5,000 years. But I thought that what I'm going to do is to tell you from an observer, from a clinician who is interested in stroke, who have spent a lot of time in my training in looking after dealing with stroke patients, and which remain a very big part of my practice these days. And so what I'm going to do is to have a look at the history and the evolution of stroke medicine. And then we try to look at what have happened in Australia, in the Australian context in the last, 30, 40 years or so. We look at, some of the key milestones in stroke treatment, and then maybe a brief word about my own experience. And we wrap up with a few take-home messages. So please ask questions. I'll try my best to answer. Love to hear feedback from the audience. There will be a lot of slides, and I don't intend to go into everything in detail. I understand that the presentation will be made available later on. So I probably may have to go through some slides relatively quickly. I hope it is okay. Before I start, I would like to thank Professor Stephen Davis and Dr. Miriam Vronsky from Royal North Shore Hospital and Professor Davis from Melbourne. They kindly let me use several of the slides from the previous presentation. I also want to extend a sincere thank to Simpi Aurora, our stroke coordinator at Rye Hospital here, who asked me to do this presentation, to give me this opportunity, for her encouragement, and also for coming up with the title of this talk. Sorry, I haven't advanced the slide. Okay, now, first of all, what is stroke? So this is a very standard definition that I'm pretty sure most of you will be familiar with. Stroke is a clinical syndrome characterized by rapidly developing symptoms and signs of focal neurology usually, but at times could be global. And that leads to a loss of brain function with symptoms lasting for more than 24 hours or leading to death. And there are no other apparent causes other than vascular or cerebrovascular disease. So it seems to be a simple concept. This is exactly how we understand what stroke is about these days. It's a rapid onset syndrome, focal neurology, and as a result of cerebrovascular cause. However, when we look back at the history, this is not how people in the ancient past understand about stroke. So we're going to look into that a bit further. Now, maybe I just quickly mention about TIA. Again, a very standard definition of acute loss of focal cerebral, but on this occasion, we include the eye monocular function lasting less than 24 hours. And again, it's presumed of vascular cause due to either thrombosis, embolic disease from different sources or hematological condition. Now, of course, many of you will realize that TIA, we are moving away from a time-based definition of TIA to a tissue-based definition. And in fact, as we know, many of the clinical TIA episodes, if you do an MRI scan, you actually see cerebral infarct. So certainly TIA doesn't necessarily mean something unimportant. Now, medicine in the ancient world. In fact, the first reference to the brain dated back in ancient Egyptian records, and the first use of the word brain itself was mentioned back 3,500 BC at that time. For a long time, brain has been considered to be an organ of intelligence and thought, but the heart was still considered the most important organ. It is the seat of mind. And it is also, they didn't understand about cerebral vasculature and blood supply, and said the brain actually didn't have any blood supply. And so therefore, in early civilization, actually, the brain wasn't given as much importance as perhaps, what we would be appreciating these days. Now, in terms of the theory of illnesses, behaviors, we need to talk about the humoral concept or theory. So essentially, there are 4 types of chemical, fluids, and liquid: blood, phlegm, black bile, and yellow bile. So, the balance or imbalance of these chemicals and fluids would determine someone's health, and whether they may behave in a certain way or have certain personality, or suffering a particular type of illness. So this is how people at that time understand about illness in general. Now, why do we call stroke? It is because it is in ancient time, stroke was known as apoplexy, which is in Greek meaning being struck down, it's a strike, being struck down. So really from the beginning, people recognize stroke is a condition of rapid onset, sudden onset. So I think that that's pretty similar to our understanding these days. So in the Hippocrates writing more than 2,400 years ago, stroke was recognized and mentioned. A person developing sudden paralysis, change in well-being, also described numbness and anesthesia. But however, what they didn't quite understand at that time is they thought that stroke was a generalized or general dysfunction of the brain rather than a focal neurologic syndrome as we understand these days. And this is despite that even in the old writing at that time, there was some recognition of unilateral neurological deficit associated with apoplexy. And at that time, based on the humoral theory, it was thought to be the accumulation of the black bile obstructed the passage of the animated spirits from the heart, from the ventricles to the brain. So it has nothing to do with circulation. Galen essentially followed Hippocrates' concept and idea and developed that further. But he did recognize a couple of things which is very important. One is, he noticed a few more clinical manifestations of apoplexy, including the respiratory involvement, respiratory failure, and other symptoms like loss of consciousness or altered consciousness and a sudden loss of motion sensation. And also he was aware that the hemiplegia was on the opposite side to where the unilateral brain lesion is. The second important thing about Galen is he recognized or identified the possible sort of vascular or blood vessels, a collection of blood vessels. These days we know that they are the so-called villus at the base of the brain, and it is called the rete mirabile. And he observed that in pigs and cows. There was no human dissection at that time, but he assumed that this is also present in human being. And so there was some very basic drawing, to sort of indicate, his concept. And he tried to combine the humorism with the vascular findings. But what is perhaps not so correct these days is, he thought the blood can pass through the septum between the two sides of or between the two ventricles, allowing the blood to be mixed. And also, Galen did not realize the pathology distinguishing between what we now know to be infarction, which is softening of the tissue, and cerebral hemorrhage. And because of this general lack of understanding of cerebral vasculature and the vascular etiology of stroke or apoplexy, it is quite likely that people at that time would have considered many other neurological, non-stroke neurological syndrome, perhaps what we these days would call the stroke mimic, to lump it together as stroke, or as what is known as apoplexy at that time. Then amazingly, for the next sort of many centuries afterwards, during the Dark and Middle Age, nothing much has progressed, since the Galen sort of idea. During the period of time, there was some sporadic new knowledge and about medicine being sort of brought in from the Middle East, from the East, and so forth. But really, the belief about apoplexy, about the brain, really didn't change for a long time. Now, then in the 14th and 15th century or so, Andreas Vesalius, then he sort of recognized the circle villus, or what these days we call circulus of the rete mirabile. And but because he was under so much pressure, because of the vascular etiology of apoplexy wasn't a well-recognized idea at that time still. Therefore, he was under so much pressure that he decided, actually, in fact, he dismissed, what he believed initially, and not until some years later on, later publication, that with a bit more support in the perhaps the science community and so forth, that he include the rete mirabile in the publication. And one thing that Andreas did recognize is, the interventricular septum is tightly closed rather than open. Now, but what really has resulted in a major blow to the humoral theory is the understanding of vascular anatomy of the brain. And we need to, of course, when it comes to circulation, we need to talk about William Harvey, which based on dissection, observation in animals and humans in 1628 described human circulation, and he recognized the role of blood vessels in the pathogenesis of stroke. And his idea was further developed by Johann Jacob Wepfer from Switzerland and Thomas Willis that I'm going to talk about in the next slide. Jacob Wepfer was quite important in stroke medicine. In fact, he discovered he described in more detail about so-called Willis before Thomas Willis did 6 years before. He sort of identified this polygon vascular structure on the base of the brain, and he sort of understand the carotid artery, follow the blood vessels in the neck, go into the brain, through the bone, penetrate the skull, and then form this network. But one thing is he didn't draw any diagram, so there was no graphical representation of what he understood. So therefore, end up so-called Willis became named after Thomas Willis, who only described that or drew the diagram 6 years later. Now, there are other contributions from Wepfer. First of all, is he described cerebral hemorrhage. He described apoplexy due to bleeding into the brain, extravasation of blood into the substance of the brain. But on the other hand, he also seemed to realize about ischemic stroke. He talked about blockage of one blood vessel and the obstruction and preventing the influx of blood and cause apoplexy. And he also seemed to have some concept about collateral blood supply of the brain. Another important contribution of Wepfer to the stroke medicine was his clinical observation of symptoms and signs and perhaps etiology, what we call epidemiology these days, of stroke medicine. He observed that the obese, those whose face and hands are livid, and those pulse were constantly unequal, are the people who seem to have these or seem to be present in people with apoplexy at that time. It was also believed that he was the first person to describe, aphasia and right-sided weakness. But even so, at that time, stroke or apoplexy was still considered to be a global brain dysfunction. But also interesting enough that, I think that because in the, as you could see in the previous few slides, looks like that the apoplexy that was described a nasty major stroke, probably what we might call this day MCA, total anterior circulatory stroke perhaps. But, Rafa noticed that there are variants and perhaps, what we these days would call TIA, perhaps minor stroke, that symptoms and signs may resolve within days to perhaps a couple of weeks. Okay, Thomas Willis. So he discovered, reported, and described this delicate interconnection network of blood vessels that we know as so-called Willis. He called apoplexy as an astonishing disease. And it is only through Thomas Willis, Wepfer, William Harvey, that the idea of humoral theory, the nervous energy, going to the brain and the upset of that, energy causing the apoplexy, that theory, gradually disappear. Okay. All right. So in the 17th century, then we turn to Italy, and a number of scholars, physicians, and perhaps anatomists and so forth sort of describe, pyramidal tract or the pyramids in the brain, where the cortical spinal tract cross. So therefore, left side of the brain pathology would result in deficit on the opposite side of the body. Morgany, was important. He was considered as a father of modern pathology, and also was a founder of this concept of clinical anatomical pathological correlation that we, these days, all medical students and we will go to clinical and pathological workshop and meeting. He tried to relay what he could observe, clinically before the person died, and what he found in the postmortem. Now he, at that time, he still sort of, again, they start recognizing between the two types of stroke, the hemorrhagic stroke and the ischemic one. The hemorrhagic stroke was known as the subcutaneous apoplexy, whereas the serous apoplexy refer to the non-hemorrhagic type. What they will write at that time is, Morgany said that you won't be able to distinguish between the two, during life. So I think it is still true these days. Then there was advancement in pathology. John Chang described cerebral hemorrhage in his publication, and backed up by postmortem finding. And he identified 3 types of pathology in apoplexy: brain softening, which is what we now know as cerebral infarct, subarachnoid hemorrhage, and intracerebral hemorrhage. Then we turn to France, in 18th country, Leon Rostrand, further sort of consolidate this concept of cerebral infarction, which was known as Romanesomon at that time, which he reported and described being distinctly different from cerebral hemorrhage. And that was around at that time that the term apoplexy started to be used to describe cerebral hemorrhage only, with cerebral infarction separating out from the terminology of apoplexy. And the other important observation from Rostrand was that he recognized ossification of the cerebral blood vessels. So obviously, probably what we now know as aromatous disease, but he couldn't associate the relationship with this ossification of the arteries, obstruction of the blood vessel, and the development of apoplexy or softening of cerebral infarct. And at that time, this theory was still under a lot of challenge because there was, pathologically speaking, people also start to understand about information. So there was some thought that perhaps apoplexy or this kind of cerebral softening, cerebral infarct were a result of a inflammatory process and encephalitis rather than a vascular event. So again, you can see that even the concept we know these days about stroke being a vascular disease really sort of, took a long time for that to be established to be realized. Then in 18th century in England, I think the idea of cerebral vascular disease and so forth become much more better recognized and accepted, and therefore the idea, the theory about inflammation as a cause of stroke started to fade away a bit, although there's still a lot of debate and disagreement. And then around that time, in the early 18th century, then people start to come up with some classification of apoplexy or for stroke syndrome of different type, and I've just listed several different classification that was published at that time. It's interesting that some of them, again, the transient apoplexy was described. So the concept of TIA started to be recognized, or Masterstroke at that time. And then in the 18th century, I think there's more recognition about cerebral infarction through the work of Wojciechowski, Welchow, Lobstein, who is a student of Virchow. And so recognizing this phenomenon of cerebral infarct. And then, later on in the 18th century, early 19th century, there more recognition of a different type of presentation of the syndrome, the different type, the atherosclerotic disease, arteriosclerotic disease, accumulation in the inner membrane of the blood vessels, causing the disruption of the circulation. And of course, a number of physicians describe the brainstem syndromes that as medical students, we try very hard to learn what the clinical signs are. And then later on, the concept of cerebral embolism started to develop, meaning that the obstruction may have come from a location away from where the blockage of the blood vessel in the brain is. And very interesting, in fact, as vegetation of the heart valve were described, back in 1755. But, the idea of carotid atheromatosis disease narrowing as a cause of stroke wasn't recognized until, in the 1950s, 60s by Dr. Miller Fisher. Similar around that time, there was also some recognition about small infarct, the lacunar infarct. Again, there have been a lot of report and description, understanding, but the pathophysiology of hypohyalinolysis as the cause of lacunar stroke, as we understand that these days, really came from the work from Miller Fisher in the 1960s, who also described the different lacunar syndrome that we learn these days. In the 20th century, I think mainly is the consolidation of the understanding of cerebral vascular cause of stroke. But importantly, I just want to mention that the first cerebral angiogram actually was performed in 1927 by Monitz. Perhaps I should devote a slide to talk about Miller Fisher, who is really considered as a father of modern stroke medicine, and in fact his contribution was really significant and shaped how our learning of stroke medicine in the modern time. He described a number of different pathology. I mentioned about lacunar stroke, cerebral hemorrhage, carotid narrowing occlusion as the cause of embolic stroke. He described large artery, some of the concept of large artery embolic disease, cardioembolic stroke of clot coming from the atrial appendage after acute myocardial infarction. And from a therapeutic point of view, he also was one of the early advocates of using blood thinners, antiplatelet, and antithrombotic. And clinically, he also introduced and popularized the concept of TIA. And he did some meticulous work on people who present with monocular visual transient, monocular visual loss, the amaurosis fugax, that he did detailed fundoscopy and see the cholesterol clot and the plaque, that you could see in the retinal ischemia. Now, then in the 1970s, we started to have CT scan, and this is a picture of, so CT was discovered by Godfrey Hansfield and Alan Cormack, and both of them got a Nobel Prize as a result. And this is Hansfield standing next to one of the CT machines, so look quite different from what we have these days. So CT was introduced in clinical practice in the mid-1970s. In terms of MRI, although the nuclear experiment sort of was kind of done and performed after the Second World War, it wasn't until 1970 when using MR technique to image for body image was understood and was established. And in 1974, Raymond Damadian invented or produced the first MRI or MRI machine to whole body MRI. I just look up, in fact, Raymond Damadian only passed away a couple of days ago. So really, the advance in medical imaging with this technique can really revolutionize, the practice of stroke and lead to our understanding of stroke medicine in the modern time. Now, sorry, I didn't advance the slide. Yeah. Maybe I just have a few words about stroke medicine in Australia. I think it is fair to say that really Australians, clinicians, researchers, scientists really are at the forefront of stroke medicine, in the past, couple of decades. And I thank Steve Davids for lending me some of the slides for a presentation that he made to the Stroke Society Australasia, the SSA, last year when we celebrated the 32 years, 32 birthday of the organization. And the Peter Braden, Professor Peter Braden, who sadly passed away a couple of months ago, established the first stroke unit in Austin Hospital in Melbourne in 1977. But his contribution to stroke medicine obviously started before that. In 1964, he published his publication to radiology. He went to see patient I believe he went to see patient in emergency who presented with a stroke, and then did cerebral angiogram to assess, cerebral vascular obstruction as the cause of the presentation. So this is exactly what we do these days for a endovascular treatment, cerebral angiogram, intervention radiology. And then in the 80s, there have been a number of workshops held in annual workshops held in Austin Hospital in Melbourne on stroke and epilepsy. And these workshops, and they invited international speakers and so forth. And this workshop really were the predecessor of SSA, which was formally founded in 1989 with Professor Jeff Donnan being the first president. He was followed by Dr. Stephen Davis. And of course, over the past 32 years, there have been distinguished colleagues, both in medical, non-medical, to be the president of the organization. There have been many distinguished speakers from overseas coming to the annual scientific meeting, which is the highlight of the society. And may I just also mention that the next ASM of the SSA will be held in Christchurch in New Zealand in a couple of weeks' time. And there are a number of sort of stroke interest or special interest group within SSA, and one of them that was established in 1996 is the Australasian Stroke Trials Network, the ASTN, which was formed in order to coordinate research activities in Australia, both commercial driven as well as investigator academic led stroke research in Australia, and is really playing an important role in organizing, especially bringing stroke trials from overseas to Australia. And every year at the ASM, there is a special session of the ASTN, which I really enjoy, that they have this quick fire presentation. Each side, talk about the research, a very brief review of how they are progressing. And although this is not part of the SSA, but I just mentioned here in terms of education is the formation of the Australasian Stroke Academy, which is currently headed by Dr. Andrew Wong in Brisbane, who really is a non-profit organization formed to really recognize the need to provide sort of kind of a well-defined, comprehensive education, stroke education. We understand that a lot of stroke physicians may not necessarily be neurologists. There are a lot of physicians other than neurologists, who are involved in stroke care and stroke medicine. And one of the major achievements in the last couple of years since the inception of ASA is the development and the formation of the stroke physician curriculum. So each year, the ASA runs a workshop, a weekend workshop. This year was held in Adelaide, and I would encourage people who are interested in stroke medicine to attend, because it's really a fantastic review of stroke medicine, very topical, very practical as well. Now, this is a webinar sponsored by Stroke Foundation, so I need to talk a little bit about Stroke Foundation as well. Stroke Foundation also celebrated recently its 25th birthday. And looking back, the foundation was founded by neurosurgeon Dr. David Brown-Bill and the late Sir John Holland in 1996. In fact, I believe that they formed a workshop or a group, before 1996. But 1996 is when the federal government, for the first time, listed stroke as a health priority, and that's when these two founding founders develop and set up the Stroke Foundation. Now, the Stroke Foundation, as we know, is play an absolutely important role in providing support to both patients, the consumers, as well as the clinicians who are dealing with stroke. So the idea is really, by doing that, working with other organizations like the SSA to really try to advance stroke medicine, the care of stroke patients in Australia, in order to reduce the burden, to support people, stroke survivor, and so forth. For those of us who deal with a stroke patient who work in stroke, we would have contact with Stroke Foundation regularly, from the envelope, the stroke recovery information that we handed out to our patient in the stroke care unit, to referring to the guidelines, the stroke guidelines, and as well as other resources and information. The Inform Me is a particular resource collection for the professional. That's where we find the national guidelines. The acute stroke guidelines was first published, in 2003. And then was updated a couple of times, and subsequently there were also the rehabilitation and more recently the childhood stroke guidelines. Now, I want to say that one thing is fascinating and innovative is now the stroke guidelines actually is a living guideline. So instead of just printing that out, a hard document which may get revised once every couple of years, the living guidelines get revised regularly. So certainly something that I would encourage everyone to refer from the website, which is very easy to use and very easy to follow. Of course, the Stroke Foundation is instrumental in a number of community campaign or education campaign. The well-recognized, probably one of the most well-recognized would be the FAST, the Face Speech and Time campaign in 2007, the FAST. So in 2008, and also in order to really, again, to really to coordinate different parties, stakeholders who are dealing with stroke in Australia in order to foster better cooperation and to minimize duplication and waste and so forth. The the SSA and Stroke Foundation together form the Australian Stroke Coalition, the ASC. Just a few more things to mention, and probably many of you would remember that, sort of in the early 2000s, there was this, I'm still quite impressed by that, there was this one-off capital injection from the New South Wales government to either refurbish or to enhance or establish, 23 metropolitan stroke units in New South Wales. And that's really the beginning, at least in New South Wales, where you see the interest of stroke, that, the hospital providing much more sort of organized stroke service and stroke care to the patients. And then, of course, in New South Wales, then in other states as well, there is the ambulance matrix to better get the patient to the acute stroke center where they could receive acute treatment. And of course, the more important development in the recent years would be the telestroke services. We understand that Australia is a big country. The population concentrate in a few cities and centers. And therefore, telestroke is a very important part of the stroke medicine. Victoria led the way, have the VST program started under the leadership of Chris Bladen in 2010. Western Australia and South Australia followed. We are a little bit behind in New South Wales, but we certainly is catching up. And only a few months ago, we start seeing this statewide telestroke service support to smaller sort of rural based hospital in the States. And there have been data now to really have demonstrate in publications that telestroke method really have facilitated sort of more patients receiving acute treatment and receiving the treatment, but more quickly. Of course, we need to have data to know how well we have done, how well we look after our stroke patients, and that's where the OSCAR, sort of come in, provide this, audit the services and support to hospitals that sign up to the program. And since I think around 2015, there is this setup of the Australian Stroke Data Tool to be a one-stop shop, to have one database where clinicians, acute care, rehabilitation in Australia can turn to for information. Last but not least, on the stroke kind of organization in Australia is the ASA, Australian Stroke Alliance, which was formed in 2021 and being co-chaired by Jeff Donnan and Steve Davis. The idea and the mission of ASA is to try to bring the treatment to the patient, the acute stroke treatment to the patient, understanding that Australia is a big country. Patient may not be able to get to the hospital in time. So one of the earliest initiatives is obviously the mobile stroke unit. Which started, I think, in 2017 in Melbourne. This is it's a modified ambulance, and inside the ambulance there is a CT machine, and of course, other imaging technology, monitoring, and so forth. And they are able to deliver intravenous to do the CT scan and deliver the thrombolysis on the ambulance before they get to the tertiary stroke center. The Alliance at the moment continue to work with partners, including universities, the Royal Flying Doctors, industries, and ambulance services and so forth, to in the process of developing a second generation, a second mobile stroke unit in Melbourne, and I believe that there will be one in Sydney as well. And they are in the process of also, hopefully, in a few years' time, to be able to build a ultralight CT machine that can put onto a ambulance, so that acute stroke reperfusion treatment could be provided to the remote community. Okay, just probably a few more slides, and the stroke is still a very relevant, it's important health conditions in Australia. So we estimate that up to close to 400,000 Australians adult will have experienced a stroke at some time of their lifetime. The prevalence and the stroke incidence rate are reducing, but on the other hand, the number hospital admissions actually, if you're looking at the absolute number, is increasing. It is more prevalent in male, more common in the older age group, and we don't, for example, we don't have a lot of data on stroke in the indigenous population, but some of the individual studies in the States, has found that our First Nation people are 3 times or have 3 times as high as the risk as compared to non-indigenous population to have stroke. Every week, there will be 100, sorry, I take it back, more than 100 stroke every day. And also sort of, 29 Australians die of stroke each day as well. And so so the death rate of a stroke is diminishing, but that means that more people are surviving with stroke. So therefore, they will need more support in the community, and therefore the health burden, financial burden, the health burden to the health system remains quite substantial. I think that, for those of us in particular working in the hospital, we get really excited about the latest development in acute medicine, in acute stroke, reperfusion treatment, rehabilitation, and so forth. I think it's important to remember that looking at a population-based approach or high-risk group approach management of cardiovascular risk factors in the community is equally important in order to prevent the first ever stroke, and for those who already have suffered from a stroke, to prevent stroke recurrence. I probably won't have time to go through all the stroke risk factors, but in fact, stroke risk factors have been recognized a long time ago, although the common risk factor, for example, hypertension, is really not recognized as a major risk factor only until sort of in the last couple of decades. So these are some of the modified and non-modified risk factors for stroke. These are familiar to most of you. And in truth, we know that 90% of the patient with stroke will be able to attribute to the risk factor to one of the 10 as listed in this table. Hypertension is the most important risk factor, so it is important for us to sort of check patient blood pressure. When patient come back, we'll go to see the GP, and when they come back to the stroke clinic for follow-up and so forth. Of course, there are guidelines in terms of the blood pressure management, and perhaps what agents and target that will be recommended. Cholesterol dyslipidemia is another one. And of course, when we talk about risk factor management, we need to distinguish between the primary and secondary stroke prevention, but I wouldn't have time to go through in detail. But again, the stroke guidelines from the Stroke Foundation, really the living guidelines, very easy to use, very clear about the current recommendation. Atrial fibrillation is an important cause of stroke, in particular in the older age group. We know that patients with AF stroke usually have bad stroke, big stroke, and of course we now have the clinical tools, the CHEST score to estimate, to try to work out the stroke risk, and to help making decision about recommending long-term anticoagulation for stroke prevention. And for many years we have only warfarin, but now of course we have the direct oral anticoagulant. Diabetes and metabolic syndrome, another risk factor, and there are a number of them that are listed here. Just touch on very briefly about antiplatelet treatment. Aspirin was recognized in the 50s, first used as an antithrombotic, and since then there are a number of trials, meta-analysis, and really find that aspirin is helpful in both, to prevent early stroke recurrence when given, soon after, within 48 hours of the stroke onset, with very low risk in terms of bleeding complication, and with and therefore so with a net benefit. So we really looking at a treatment every 100-something patient or so to produce one good outcome. There are a number of other antiplatelet therapy, but we know that in the acute setting, anticoagulation is not considered to be helpful. So again, the Stroke Foundation has provided a guideline in terms of the acute stroke sort of blood thinning medicine. Again, in the 90s, there are many of them sort of pharmaceutical companies sponsored a secondary prevention trial to look at a combination of antiplatelet therapy in long-term stroke prevention. So, there has been for a little while astaxanthin, which is aspirin plus dipyridamole, were really the recommendation, but unfortunately there has been supply issue with astaxanthin in the community. Anticoagulation, I think I mentioned about atrial fibrillation, so I'll probably move relatively quickly. We now have 3 different types of what used to be called novel oral anticoagulants or new oral anticoagulants for AF stroke prevention. As a group, they've been shown to be as compared to dose-adjusted warfarin, to be more effective in stroke prevention, causing less hemorrhage and cerebral hemorrhage. And in the meta-analysis, this doesn't seem to have any major GI bleeding. Again, another recommendation from the Stroke Foundation. And also now we recognize that we mentioned about Dr. Miller Fisher sort of recognized atherosclerotic disease in the carotid artery embolizing as a cause of stroke. And then the NEST trial and the European carotid trial, which published around the same time, to really in the early 90s, identify that, for patients with symptomatic carotid disease, 70% narrowing and greater benefit from carotid endarterectomy that are performed in good center with a low complication rate, and also there is clear evidence to support early revascularization. Stroke unit, I need to mention, stroke unit, the concept, started in the 60s and 70s and sort of mirroring, the success of the coronary care unit. But it was not until a little bit later when really we are following a rehabilitation-based model that a multidiscipline type of model for organized stroke unit to be staffed by therapists and clinicians who are interested in stroke, who are involved in ongoing education in stroke, like what we're doing today, that produce the positive outcome. It saves life, so Every 28 patients or so we treat in the stroke care unit, we produce one better outcome. Important point about the stroke unit is really it provides the opportunity to really enforce a protocol-driven intervention, looking at fever, hyperglycemia, swallowing, the CRAS initiative that has been shown to produce a better outcome. But although, of course, I won't have time to go through that, it will be a topic by itself. We do recognize now, the importance of to establish reperfusion, recanalization of blocked artery, and reperfusion in order to salvage penumbra in the acute stroke, acute ischemic stroke setting. The idea is after a thrombus occlusion, part of the brain would be injured irreversibly. That is an infarct, but there is an area surrounding that ischemic core that is a penumbra that is potentially salvageable if we are able to open up the blood vessel and to provide the reperfusion. We now have the advanced imaging technique, both with CT, which is more commonly available, as well as with MRI in identify potential ischemic penumbra so that to guide our treatment decision. The key is time is brain, because the longer you wait, the salvageable, potentially salvageable penumbra tissue become infected, and commonly quoted 2 million neurons will die for every minute of the arteries is occluded so that hasn't had perfusion. So the idea is to open up the blood vessel to reestablish the perfusion and to reduce tissue injury and improve outcome. We now know that we can achieve that by both thrombolysis or endovascular clot retrieval. So I probably may, as I said, I apologize that there are a lot of slides and a very big topic to go through, but maybe I just sum up if I may, so that hopefully we will have a couple of minutes to for some question. Just a word about my personal journey in stroke medicine and stroke care. I must say that, perhaps the really early real exposure to stroke care medicine is when I was a geriatric medicine advanced training at Westmead Hospital. It was really a unique opportunity because many of you may know that the geriatricians at Westmead Hospital look after older patients aged 70 years older. So it really sort of gave me an opportunity to be involved in acute stroke care as well as in rehabilitation. And that was obviously at the time when the major funding from the government in enhancing existing stroke units. And then I went on to train in neurology formally, and obviously have been inspired and learned from many distinguished neurology mentors, neurologist consultants. And that is, the time when we start using actylates, TPA, quite routinely for acute stroke patient, initially at the sub 3 hour window and later on extended to the sub 4.5 hour window. Then I returned to Westmead in 2006 to be the inaugural stroke fellow and was able to involve in implementation of a number of the stroke services, both at Westmead and later on in Blacktown Hospital, which is a peripheral hospital of Westmead. And at that time, again, sort of be inspired, encouraged by many consultants and mentors. But, in particular, during that time, learn from, Professor Richard Linnick, professor in geriatric medicine, who really have been involved in stroke trials for a long time and sort of involved in the IST3 program. So just quickly is, I think we have come a very long way for stroke medicine and the treatment. When I was a registrar, I was told that we learn neurology stroke by stroke. So it really indicates and signifies the importance of stroke medicine development and evolution, mirroring, our understanding of neurosciences and clinical neurology. I feel that I'm probably biased, and many may not be disagree, but I think really stroke medicine and stroke care is a uniquely multidisciplinary branch of medicine. I couldn't think of a branch of medicine that have involve specialists, doctors, GP, specialists other than neurologists, clinicians, therapists, and so forth. I think it is a very exciting time to do stroke medicine, and no doubt that Australia is at the forefront in research and in innovations. We are looking at the mobile stroke unit service and the Stroke Alliance initiative is fantastic. There will be major challenges and barriers, no doubt about that, but every challenge is an opportunity. So apologize, for the long presentation. I hope that I have taken you through a journey of stroke medicine. But if there is too much to remember today, just remember time is brain. Okay, I may stop here.
Thank you so much, Dr.
Sorry,
Ip.
Ashley and Melita.
It was a fantastic and very interesting presentation, and it was great to go on the journey with you on the timeline of stroke understanding and management, and who the key influences were from ancient Egypt and the Middle Ages right up to contemporary times. So I think, as well as you giving us a really interesting historical view on stroke, your presentation about what's happened in recent times really highlights the vast amount of work and dedication by the organisations and researchers and clinicians, and all of the benefits that that's brought to people being treated by stroke today. So thank you so much for sharing your knowledge and expertise with us.
Thank you. Yeah.
We're a couple of minutes over time, but if anybody would like to stay online, we do have a couple of questions that I'd like to put to you if you're able, Dr. Ip. So the first one is for patients with AF currently on anticoagulant Pradaxa. Is it necessary for them to be on antiplatelet for stroke prevention?
Not conventionally. In fact, I think the guideline, has put forward that this is not something recommended. I'm pretty sure we have. There are some circumstances that certainly myself and perhaps clinician colleague in the hospital have add-on antiplatelet therapy. Some of them may be for cardiac reason, although I think there was some controversy initially when Pradaxa come into the market, whether it provides as good protection for coronary artery disease as compared to warfarin, and certain there have been situations, perhaps I have a patient who have AF but also maybe have a stroke as a result of carotid disease, and despite good compliance with the NOAC, still have stroke, then I have add on to some antiplatelet therapy, but I must say that it is at the end is a shared decision-making process with the individual patients rather than a routine practice.
Okay, great. Thank you for that answer. Another question that we've got here is our understanding of stroke has changed significantly over time. How complete and accurate is the understanding we have today, in your opinion?
Yeah, you mean in reference to the future? I think still, I suppose, we won't, the definition of stroke being a vascular, cerebrovascular probably won't change, isn't it? I think that I would think that, the development probably will still focus on and evolve around, perfusion, of the established perfusion and so forth. Of course, they have a lot of, perhaps, research, I suppose, may look at whether there may be some sort of inflammatory, contribution, to the mechanism. But I would think that if you look at the history again, I think ultimately we come back to the vascular nature of the condition. Yeah.
Great, thank you very much. We will wrap it up there because we're 5 minutes over time. Thank you, everybody. There are lots of comments here about saying thank you very much. It's been excellent and very comprehensive presentation, really enjoyable, great overview of stroke. So obviously the audience has really appreciated your presentation, Dr. Ip.
Thank you.
And
thanks very much.
for those whose questions we haven't been able to answer, we will email you with a response afterwards. So thank you so much for your questions. Thank you for being part of the webinar. And I'll now hand over to Ash.
Thanks, Mel, and thank you, Dr. Ip. That was a really informative session. I've learnt a lot, so thank you for that. We will be sending out an email shortly with a link to this recording, a PDF of the slides, and a link where you can complete the survey and register for a CPD certificate. So please keep an eye out for that. And if you haven't already, don't forget to head over to the National Webinar Series webpage on Inform Me to register for part 2 of our Vision series tomorrow at 2 p.m. Australian Eastern Standard Time. We really hope to see you there. Thank you again to everyone for joining us today. Thank you, Dr. Ip. And
thanks very much. Thank you. Thanks, everyone. Thank you.
Bye.
Thank you for being with us.
Bye-bye. Yeah.